So let's see. Okay, yes. All right, we're recording. So, OT practitioners are the only ones, even amongst other healthcare practitioners or professions, that look at occupation and how essential that is to the fulfillment of one's roles, as well as even just health and well being. And that's why we have the occupational profile. And that's why that profile, in the profile, you need to focus on those things: roles, occupations, the client, not do they need OT. The That will kind of come out as the report goes on. So, what does an evaluation include? What are those components? And you'll see I have bullet points under there that, or things that you might want to take notes on or note that are aspects of that evaluation. First of all, you are going to probably do a chart review or some kind of a paperwork review. Look at what other medical professionals are telling you, whether it's the physician or maybe they've already gotten PT or speech or something else, and then they're coming to you. So you want to kind of, do your homework before you even meet with a client. Then you meet with a client, and I will tell you this, and I can't stress this enough. The most important part of the evaluation is the client interview. It doesn't matter if you are expert level at 100 different standardized tests or 1,000. It doesn't matter if you know every bit of evidence that's ever been published on intervention for a certain diagnosis, and then somebody with that diagnosis comes to you. In every case, the most important and most information providing or most informative aspect of the OT evaluation is the interview. Now, sometimes there are clients that you will be working with who maybe can't give you the full interview themselves. Maybe they have some cognitive impairment. Maybe they have some language impairment. Maybe they've had a stroke or a brain tumor or something neurological that makes it hard or impossible for them to communicate verbally to you. Maybe they're little kids, and what they want to talk about is, can they get on the swing set in the corner of your treatment room, rather than what's their medical history, or are they enrolled in school full time, or how do they play with other children, that sort of thing. So you may be asking other people, obviously with permission. You may be asking caregivers, spouses, parents, adult children, other things like that. So what you're doing is you're gathering data to fill out that occupational profile, just like you did in this class. You want to gain an initial understanding of the client's occupational history. And I don't just mean what jobs they've had. I mean, what are their roles, their priorities? What does the day in their life look like? And has that changed recently? Because a lot of times when a client comes to you, it will have. Maybe they love to get up and go play racquetball or walk their dog or go run 10 miles like Dr. Weiserpike. And then suddenly something happens and they can't do that. So you want to know about what their usual or their desired daily routine is, but what is it also like now? What are they putting in place of that, to look at? You also want to, this part is very important, identify client strengths, their interests and values, as well as their needs, or we might call those their problems or their areas of weakness. So that goes back to our big discussion about why OT is really truly holistic and why we use a top-down approach in our thinking in OT. We don't just say, why are you here? What's your problem? What's wrong? What's the matter? With that, you are going to keep filling in that profile, but you will also include standardized tests. You're going to learn more about those, or maybe you already are, in EBP. Those are things that have been researched. They are assessment tools that have been researched. They have a reliability, a validity. The results can be compared against peers or like individuals. So if I give a cognitive assessment to maybe a 70-year-old who's recently had a stroke, what that is doing is comparing those results to other people in that age group. And often they'll even compare it to people with a similar educational background, people of the similar gender. It makes it where you're comparing apples to apples. Now, it's also sometimes a good idea to do non-standardized assessments. And there are lots of those around, and I'm not at all saying or implying that those don't have benefit. There are benefit and pros and cons to each of those. So in your courses that are about to start here pretty soon, you're going to be learning about those things. Specifically in biomechanics, just as an example, you'll be learning about some non-standardized assessments that are called range of motion. You'll be doing manual muscle testing to test strength. You'll be looking at balance, endurance, those different things. And so you're gathering data is really what's happening in the evaluation. You're learning what's important to that person or client, what a day in their life is like, and then gathering data so you can start to look at what of their performance skills are potentially problematic or barriers to their occupational performance. And the last part of the evaluation is actually the development of an intervention plan. Now, this sometimes trips up students if they see it on an exam or a quiz, or if they're just asked, okay, if I say intervention plan, what part of the OT process is that done in? And a lot of times people will say, oh, intervention, because it has the word intervention in there, but you actually are getting that plan together based on the occupational profile and your other data. So it's really happening at the very tail end of the evaluation. It's kind of like making a grocery list before you go to the grocery. It's going to work way better if you do it ahead of time based on what you know, and you can, look to find out more if you realize there's a gap in what you know. All right. Step number 2 in the OT process is the intervention. And this one it's got the most components to it. I think I would definitely say it's the one that you're going to spend the most time on. If we compare that, many times that evaluation is really done in one session, or maybe it's done in a session and then a little bit of outside work to calculate the standardized test scores and things like that. But the intervention can last a day, it can last several days, many days, months. It could really even last years in theory, although you're going to come back and do reassessments in between that to make sure you're on the right track. So OT interventions, and this is straight from the OTPF4. We know already that interventions in OT include occupations and activities. Hopefully those are both meaningful to the client. It also includes the use of occupation as an end, or in other words, interventions that support occupational performance. It also includes education and training, both for the client and for other support personnel and caregivers. Advocacy, including self-advocacy. There have been a number of interventions that I've done with people, even sometimes elementary school aged kids, but definitely young adults and adults, where what we are working on is self-advocacy. Standing up for yourself, realizing what your rights are, and then practicing how to voice that or how to ask for help. Group interventions and virtual interventions, and we've kind of talked about those already. Those are all considered part of the intervention process. What we're trying to do through intervention is to facilitate occupational performance or occupational engagement, really looking at how individuals, despite their diagnoses, challenges, barriers, how they can fulfill the roles they need and want to through occupational performance and really get to a point of good health, well-being, a feeling of quality of life. So it's also important to note that an intervention is done with a client, but as you know from what we've already talked about in this course, a client doesn't necessarily mean one single person. It could mean a few people, a small targeted group, or a bigger population for sure. And so, what we do in the intervention process is in other words, how do we know what to do with a client? I already said there's not a recipe book. So, how do we know? And the answer is really, we're going to learn pretty soon about different theories that different OTs use. It might depend on the setting where you are. So, how long you have to work with that client. Sometimes it's just 1 or 2 days. That'd be like in acute care. And then they're going to go somewhere else and somebody else would be their OT. But for your time with them, it's very short. But sometimes you're going to have months or sometimes even longer, like in the school system. A lot of times you work with a client from the day they turn 3 until the end of the school year after their 22nd birthday. And get to work with them for that long. So it's not the same intervention for all those years, but you are kind of on their care team or throughout those years. So you're going to choose a theory, and we're going to talk about that pretty soon. You're going to, look at your data that you collected in the evaluation process, including the occupational profile, and then look at the evidence. What do you know based on your experience, based on your education, based on what's out there in the literature? What do you know is the best choice or has the best chance of being the most effective for this particular client? And all along the way, you are going to keep in mind that you need to always be client-centered, culturally humble. So always keep in mind the client's culture. You guys, from the occupational profile reports I've seen so far, y'all are doing a good job at that. Always keeping that in mind, what's important to them and in their context, in how they grew up or their social system or support system might be very different from what would be important to you or what you think would be important to you if you were in their shoes. That's again why we can't have like a cookbook for interventions. Now, if you look at table 13 in the OTPF, you will see that there are 5 main approaches to intervention in OT. This is important for you to know what these are and also to kind of be able to generally explain in your own words what each is, and then to think of an example, or if provided with an example, to be able to match it with one of these. So let's talk about it. Create and promote. Those two things are grouped together, those two intervention approaches. What that really looks at is using activities, or an example of that could be an activity-based program that an OT might develop to help brand new college students adjust to environmental and academic demands of their new role as a college student. So you're starting something new there. That's something to look at, really. And you are promoting something rather than really rehabbing it, I guess you could say. You're not necessarily trying to fix it, you're being more proactive to that. So that's the first one. Now, if you go on down table 13, you can see the second one is establish and restore. Now, think of this as more really kind of what a lot of people think about as rehab. It's a remediation or restoration of skills And an example of that could be something like if the OT practitioner worked with an adolescent client that had been in a car wreck and had a traumatic brain injury, and we're trying to restore them to be able to complete their morning grooming routine independently. So that's an example of that one. Now, the next one is maintain. This one is a little bit tricky because sometimes third party payers, like insurance companies, don't want to pay medical professionals just to maintain. They don't really necessarily see that as something that's worth their money. They want to see us get people better. And sometimes, due to the diagnosis, that's not really realistic. So, an example might be somebody with a degenerative condition like rheumatoid arthritis, or even a more obvious example is going to be somebody with a neurological condition that is going to eventually result in their death. A very obvious example of that might be ALS or Lou Gehrig's disease, and we're going to learn all about that in Neuro Aspects, which will start in July. But something like that, it really is progress to maintain as long as possible. Because without it, evidence or research shows that there's a more dramatic decline in their abilities and more risk for problems like pressure sores, contractures, pain, depression, things like that. So there is a benefit there to OT in helping someone with a degenerative or neurodegenerative condition to maintain where they are. And that could be an example when you're thinking about maintain. Think about an example of a condition that is going to have a decline to it. You're not going to be able to help them heal from it. It could even be like a hospice situation or someone who is terminally ill, and we want them to maintain their dignity, their mental health, their spiritual beliefs or practices as long as possible. And so OT might be on the team of people caring for a person like that. Modify, that's another one. And this is probably the second most common way that people generally think about rehab services or OT. For modify, we're looking at not necessarily changing what the person is doing. We are helping them to compensate, or, one of my favorite words, adapt. And sometimes this is happens when it's an ongoing condition that's going to really probably affect the person for the rest of their lives. So again, there might not be a cure. So osteoarthritis or might be an example of that. Something like that that's really going to affect the person long term. And in OT, we're not going to cure that, but we can help them modify or adapt what they do and how they do it to give them a better quality of life and to protect their health and wellness against things that they're at risk for, like injury due to unsafe practices, or for further damage to the body. So an example of that, here's an easy example, is if somebody's a school-based OT and they realize that there's a student who has ADHD and they're having big time problem focusing in the classroom, and the OT really does what we call like an environmental scan and checks out what's happening around that person that's affecting their occupational performance or their fulfillment of their role as a student. And what the OT might notice, and this happens a lot, is there's a lot of what I think of as busyness on the walls in the classroom, and a lot of sometimes kind of clutter or physical obstacles in the physical environment that are likely impacting that person's ability to focus and engage as a student. So think about this. I mean, we can all, I think, relate to that somewhat. Some of y'all may be able to thrive in a really physically chaotic environment, but I'm not one of them. I mean, I can do the middle of the road, but if there's the TV on in the other room and a dog barking, in the yard behind mine, and I've got wads of paper around and a bunch of broken pencils, and there's just a lot going on, it's hard to focus. So that needs to be modified. And not only can the OT in that case actually do that modification, but they should teach other people, including the client, or in this example, the student, to do that themselves. So that, the job of the OT is not just to clean up the room or tell the teacher to not have many posters on their wall. It's to teach others how to advocate and recognize and modify or remediate situations like that for themselves for the future. So that is the fourth intervention approach. Last but not least is prevent. This one I think can be a little bit tricky because people get it sometimes confused with create and promote. So the first and the last one that we're talking about now, sometimes people get confused at that. But here's the difference. Create and promote doesn't assume that a disability or an illness is necessarily present. Oftentimes that it's a group or an individual that's just at risk for something like that. But prevent is what's used when there is a disability present. So this approach is really designed to address the needs of people who are at risk for occupational performance problems, but they are probably already seeing those problems, or somebody is. Those problems are already present. So in a lot of cases. So it could be that there is a gardener, or somebody that owns a lawn service, we'll say, who maybe has a history of back injuries, or even just somebody who has poor body mechanics. And so what the OT might be consulted to do in that case would be to teach the client better body mechanics. So there would be an assessment or observation of that. And then, to get them into the habit, looking at those performance patterns of where they're not doing those to prevent injury, looking at the ergonomics of the situation. Okay, any questions about that stuff so far, or comments? You know what, I'd love to hear somebody talk about what you guys have already seen in clinical settings, and how you think that fits with any of these intervention approaches, because you probably didn't know this terminology, or that there were just these 5 approaches. What have y'all seen out there clinically in terms of OT intervention approaches?
I saw a woman with ALS, and she was 32. And I didn't realize with the maintain, like I didn't realize like what you're saying with
Yep.
paying it, like that they wouldn't even want her to be maintaining, but it was like, I don't know. It was just, she's really young to have had ALS and stuff. So that was weird.
Yes, that's rare for a couple of reasons. One being that is very young for that diagnosis, and the other being it's much more common in males than females. When we see it in that age group, it often is somebody with a military background, and they don't really know exactly why. Somebody who's been in the Gulf War, something like that. But usually it's older people that get that. So that could be particularly tricky because she probably had some, household, family, and employment responsibilities and
Yeah.
roles. Yeah.
And
But
I think they kept misdiagnosing her because they didn't think it was ALS, and she had a daughter, so it was like really hard for her and everything.
yeah, I can really only imagine that is really hard. And there's a lot of emotional components to that. We'll learn all about that diagnosis this summer. So definitely maintain. And, that's something that actually, if you didn't know what the evidence said for that condition, given that it's a neurodegenerative condition, people are going to decline, and it's actually at a fairly rapid rate, over 2 to 5 years after diagnosis is usually the lifespan of somebody with that diagnosis. And if you didn't know that, or even if they had the wrong diagnosis and nobody realized it, you might think, well, they're just really deconditioned, is why they're having that weakness or the tremors. And so let me give them a harder workout. And that actually could be detrimental. So that's important. We would really want to focus on intervention approaches with that person that are going to promote safety, health, well-being. And so you might do some modifying, especially in early stages of that disease, but also really looking at maintaining. To anybody else? I know y'all have all seen some stuff out there.
I feel like can you hear me?
Yep, you're good.
I feel like all of these were seen for me when I shadowed a school OT. I did the elementary school down the street from me, and she was constantly like creating obstacle courses in her room and doing like this swing. And then when they had handwriting problems, she would make a certain pencil to fit their hands and their grip. And then she would also do like coloring activities. And I personally walked away like it was interesting, but it's not something that I want to like pursue. But and then preventing, like she would go into the classroom and help them sit right and like adjust different stuff. So it was like all of these were in there.
Yeah, that's a really good point. I mean, you guys know that I was a school-based OT for many years, and my work really, because a lot of what I did after the first 7 or 8 years that I was there and kind of did the stuff that Tatum just said, then I went more into the assistive tech specialty. And so I traveled between schools. And at the time, there were 52 schools in that district. And I went to all those schools to look at the technology needs of children with disabilities, and especially things to support communication or written output, what to do if somebody couldn't ever hold a pencil, or maybe their hands were so contracted they could not type in the way that we do. And so there's a lot of troubleshooting. Definitely no cookbook for that, because every case is different. And also because technology is constantly evolving. So when speech to text, that function first came out, it was awful. And certainly for people with disabilities that maybe don't have that vocal projection like we can, like, if you're talking and you're trying to make the words pick up and it's not, slow down, enunciate more, and maybe speak a little louder so it'll type what you want it to. But sometimes somebody with a disability doesn't have, they can't sit up straight, so they can't get that breath support and really project. And so that didn't often work. When we tried it, it would come out as nothing or totally different than they wanted. And so there was a whole lot of mixture of this stuff in that role, for sure. Anybody else want to share something you saw that relates to some of these intervention approaches?
Last year, I don't know if you guys can hear me, but I worked in acute care, and I worked as a restorative tech. I had this one patient who had neuromyelitis, and it was caused by a car accident, and he didn't even know he had it. And slowly he came into the hospital completely like us, like able to move, talk, see, everything. And slowly he lost his eyesight. His muscles started to tighten. And what else? There was a lot of other things that happened, and he lost a lot of his abilities that he could do every day. And so basically what I did as a restorative tech was work on range of motion with him, so he would maintain his daily functions that he'd be able to do. And then what else did I do? I would put compression stockings on him to try to help maintain his blood pressure, so that the therapist could then get him up. But then like I saw therapists do a lot of things with him, like using the grips around the utensils and trying to brush his teeth, bathe him. But he didn't end up, doing that well. And it just progressed over time, but we tried to maintain it as well as we could.
That's fascinating, Audrey. That's not a common condition that you see, and especially from something like that. I mean, you see other things that are sort of like that, but that's fascinating, really. Very cool. Anybody else?
I just know one of like my favorite clients I got to see was in a sniff, and so he'd come in with a stroke and like had no use of the left side of his body, and so I was ended up being there shadowing for like 2 months, and so I got to see him like to get to the point where he was standing and walking a couple feet with the 3-legged walkers or whatever, and so that was really neat just to see him and see how like well and how appreciative he was for OT. It like really solidified like, okay, this is what we're doing.
I can totally see that. I mean, that's kind of the good stuff right there. I mean, you almost do that without getting financially paid, because you're getting that reward in the outcome of that client for sure. And so I want you to keep these terms in your head, and it'll help you explain OT a little better. And you also can get a better idea of what to do with different clients, as an example, using this short list and the explanations that are there in the OTPF in Table 13. If you are called upon to write an intervention plan, and you will be in the near future, not in this course, but coming soon to a class near you, it's a really good idea to pull this table out. I mean, this is, like I told you a few weeks back, that I don't say that you need to print out a lot of stuff, because I know, we're trying to conserve paper and that kind of thing. And also, if you're not on campus near a printer, or they're not working or whatever, it's a hassle. But the OTPF is something you should print out. You are going to use it in really, I think, every course, or darn near every course that you take the rest of OT school. So don't be a stranger to that Table 13. All right, so let's talk about the final step in the OT process, outcomes. Now, there's a lot going on in this slide, and I don't like super busy slides, but I couldn't think of how else I might demonstrate or portray to you guys that there are a lot of different outcomes. I think if we went out on the street right now and just found random people, especially if you were off the UTHSC campus, so you're not asking medical people, you're just asking random people. Maybe we'll meet at Cooper Young and just go around and ask people, what do you think is the main thing people might get from OT, or maybe we'll say rehab, because they might not really know what OT is. I think most people would say, well, the patients get better. They get back to doing what they want to do. And it's interesting because, and this was not that long ago for you guys, so I bet you can remember it, when prospective students interview for this program, one of the questions we typically ask is, what do you love about OT? Or what is OT? And a lot of people, probably, I should do a statistical analysis on this, but probably half the interviewees will say it helps people get back to what they need and want to do. And that's not untrue, but it's not a complete picture. So here is the complete picture. And this is, again, it's clarified in the OTPF. This time it's Table 14, just after that last thing we talked about. And so that's worth a read. And I like to read it with a highlighter so I can really underline or highlight things that stand out, or that I think are exceptionally important and relevant. But outcomes are obviously the end goal of the OT process. They describe what clients can and hopefully do achieve through the intervention that comes after the evaluation. Some outcomes are measurable. Maybe, and we always want to make those outcome goals relate to occupation. So I'm not going to have an outcome goal be something like Mr. Jones will have better balance when he's done with OT. Because what does that mean? And who cares? Why? There's too many questions. So we need to narrow that down. So instead of that, we're going to relate it to occupation and maybe say through OT intervention, Mr. Jones will complete his cooking routine to prepare a meal safely with demonstrating adequate balance, something more like that. So then see how that, it's really kind of the same thing, but it's a much prettier frame. It's much more related to the role this Mr. Jones I'm making up in my head might want and need to fill. It doesn't, really, it's not that motivating to think if somebody has good balance, but if we relate it to something in their daily routine, an occupation of theirs, then it is important. You can't miss why it's relevant. Adaptation is really the name of the game in what we do in OT. We don't just get them back to where they need to be. We take if that is possible with their particular diagnosis, it's a different path. It's not just a straight path, like they couldn't do it and now they can. Often they're kind of setbacks, or we'll try something and it doesn't exactly work. So we got to try something else. Maybe we say, oh, you need a built-up handled utensils and kitchen tools, and then you'll be able to do it. But we realize that if the person's main problem is balance, that's not actually, that might help them, but it's not going to solve the problem. We need to dive deeper into that. So what we're doing in this outcome phase is measuring, how far they've come. So sometimes you're redoing those initial assessments that you did, and you're looking at their progress in relation to occupational performance. Now, two important things I want to say here is whenever OT services are ending, always want to think what's next for this person. OT, I think, hopefully has a reputation for not just dropping the ball, not just dropping the client off at the street corner, so to speak. So we're not just going to say, all right, your insurance approved 15 visits. Today's the 15th visit. Let's do another session and then high five, you're good to go. Never should you say anything even remotely similar to that. You need to do a recap with them, talk about where they were at the beginning, where we thought they would be, and then where are they? And then what's next? Sometimes it will be a true situation that somebody's insurance will only cover a certain number of OT sessions. That's not great. Nobody loves it, but that is the reality. So you have to really budget what you're going to do with them, and the fewer sessions they have, the more education you need to do along the way, because they and their caregivers are going to kind of become their own therapists once they reach the end of those sessions. Now, another thing you might be able to do in a case like that, or if maybe you're working with the client in, let's say, acute care, and they're only there a few days, and then they are going to a longer-term rehab facility like Encompass. Maybe they're going from Regional 1, but once they're medically stable, they're going to go to Encompass. So the focus there can be rehab, rather than just, nursing functions and, getting their blood pressure stabilized and things like that. So you then, part of your job though, is writing a good discharge report so that the next therapist can see it and pick up where you left off. And a lot of times, especially if it's a local situation or for sure where they're going, you can even talk on the phone, or I guess these days you could Zoom with that other therapist. Now, of course, you need the patient's permission. You're not just going to call and talk all over town about them, but even to other medical professionals. But if you have their written permission, which usually people are happy to give, you can talk about, this is what they really liked. We tried this and it was, not good, at least at that stage of their recovery or rehab process. So we're looking at all these things. I like role competence to me. And, I say occupational performance all the time. That's a good question. Discharge report is part of the outcome. That's a really good question. It is what the outcome is, kind of like your review of everything, but then you're wrapping it up with a bow. You're going to look at the transition, or in other words, what's next, and write. Typically, there'll be a special report that you're writing. It might just be part of your regular report writing that you would do after every session, but you want to kind of end with a summary. What happened and what's next? And the other, so I said there are two important things I didn't want to forget to mention. One is the transition to whatever's next. Maybe they didn't have insurance and they came in and they did get acute care services because, it was whatever they had was life threatening, and OT was provided as part of that. And honestly, the hospital will probably write that off because it's going to be a lot of money and the person probably won't be able to pay it. But so maybe they're going home and they're not going to have other services. One thing you can and should do is try to find some pro bono services for them. Maybe it's even telehealth, maybe there's somebody out there or another school program. For example, we have the pediatric program that does a lot of pro bono work. Now there's an OTA program in Memphis that does some of that in terms of adults. Some of it they do charge for, but some of it they do pro bono, and it's part of the training of their students. And so you might be able to hook them up with that, which would be really good. And you see how that relates to the code of ethics. You also can release them. And here was my second thing I didn't want to forget to say, with what's called a home program. Now, you're going to hear this and see it out there, and a lot of y'all probably already have. Oftentimes, it's the term that is used for that is home exercise program, or it's abbreviated HEP. But I want y'all to help me change that lingo within the OT profession, because we're not just about exercise. It's actually, there have been a number of studies. One of them, Dr. Williams did, that shows more consistency in following through from discharged patients if the home program is activity-based rather than just being exercises. So the activity might be, full clothes 3 times a week for at least 20 minutes. It might even be wash dishes by hand instead of using the dishwasher. So you practice your standing tolerance and move your hands around. That's not that hard to do. It's part of your daily routine. But if I say, I want you to squeeze this sponge 100 times every day, I'm going to go ahead and put a little bit of money on the fact that you're going to do it about 3 days and then get bored with it and be done. I mean, I know that some of y'all have gone to outpatient therapy before, and for some of you, that's how you found your way to OT, which is great. But you could probably relate to the challenges with motivation when it's a straight exercise program. They send you home with a TheraBand, the big rubber band, and tell you to tie it to a doorknob or put it on your ankles and then do 16 of these and 14 of these every day for 6 weeks. And I don't think most people do it more than a few days. Or maybe they do it and then they feel so guilty, so they won't do it for a week, but then they're like, oh no, I better do it. So what we know, that if it's occupation based, if it is motivating, if there's that clinical carrot, besides just this will help you long term, if it's fun, they're going to be so much more likely to do it. If somebody's working on, maybe they've had a brain injury like a stroke or something happened in a car accident, and they're working on cognition. Maybe that part of their brain is part of what's happening. And so you want them to do something that helps them work on their cognition. So you can have them do worksheets or tell them to, read a paragraph in this manual every day. Or you can tell them to play a different board game twice a week with somebody else. Guess which one is probably going to actually get done. So I don't like it when OTs constantly use the term home exercise program, because I think it should just be home program. So that's my little soapbox with that. You'll see it both ways. And sometimes OTs say HEP or home exercise program, and they just mean home program. That's the lingo that's out there. All right, we are at just a couple minutes past 11, and I want to give y'all a few minute break, and then we're going to come back and talk about activity analysis. In case you're wondering, this is me here in the middle. That's my grandmother and my younger sister, Jennifer, there, a long time ago. Back when there were merry-go-rounds at playgrounds. I'll leave this picture up, and let's take 5 minutes. So we'll come back at, we'll say 11:06.
I have a quick question, Dr. Lancaster.
Sure.
So when we're talking about like the process,
Mhm.
a lot of the examples are like physical, but could like behavioral processes be tied in with all that? Because
Yes.
like I worked as a behavioral technician this summer, and for like one-on-one ABA therapy, and like the client that I worked with really struggled with like her emotions and expressing them in appropriate ways versus like biting and stuff.
Mhm.
And so like when we finally had the breakthrough of her saying, I'm frustrated, would that be part of the process or like the outcome that we were looking for? I don't know if that makes sense.
You're very close, and that's a really good question. That's a big topic in the PEDS courses. It definitely is a good topic to talk about and think about as an OT student and practitioner. So the difference here is that you want to tie it to occupational performance.
Okay.
So why did you want that child to be able to say I'm frustrated or whatever else emotions? And the reason is because we want them to have socially appropriate behavior so that they can play with other kids or be in a classroom or go to Target without, biting the kid that's also on the toy aisle, those kind of things. So yes, that is the OT process. And you would do that assessment. You would always look at, for behavior cases, you would always look at their cognition, their behavior, and also their sensory processing. As many times that's actually what's going on with behavior. And then you would develop your intervention plan. Then you would do the intervention. And you very well may work with a BCBA or, somebody else who's a behavior specialist in that. But your focus, and that would be that kind of interdisciplinary work, their focus is going to be the behavior, but your focus is going to be the occupational performance. Does that make sense?
Yes, because where I worked was a clinic that only had BCBAs. They didn't have any OTs. They had speech, but no OTs. And so I was kind of thinking in my head, like trying to relate it back, but I was struggling. So I thought I'd ask.
I'm glad you did. And, it would be a little bit the same with the speech therapist. That does go very hand in hand with behavior, language and behavior. And then kind of the third part of that triangle is cognition. But, what's a speech therapist's goal is for someone to produce language or to understand language. And that's good. But in OT, we look at why, who cares, why do we care? And the answer is always occupational performance.
Perfect. Okay. Thank you. That makes more sense.
Good. I'm so glad. That's a really good experience. You just always have to keep coming back to occupation in your head.
Dr. Lancaster,
Yes.
have you ever worked with a patient or a client who is deaf?
Yes. Several times. Yes. Yes.
So, how do you know sign language?
Pretty basic.
You.
Okay. A lot of times, the OT doesn't know. It's really similar to when I've worked with clients who don't speak English or don't speak English well.
Mhm.
What happens is the law requires that the company that I'm working for or that the school system provide an interpreter. So many people, I mean, there were many times when a student in the school system was deaf
Mhm.
and they had a full-time interpreter with them. And so that who obviously is fluent in sign language, and they would come to their sessions or be right next to them in the classroom with them. So it was kind of interesting because in that case, like they're teaching me certain things, but I'm teaching them certain
Yeah.
things. So it's very interprofessional in that case. It's
We
a lot of fun.
in our hospital back home, we had a patient come for OT and PT at the same time, and he was
Mhm.
deaf. And we thought that his mom was going to stay and interpret back and forth, and that was going to be great because none of us really knew fluent sign language. I could probably tell him how to go to the bathroom, how his day was going, rate
Yeah.
his from 0 to 10.
Yes.
And so his mom left, and we were like, wait, where are you going? And we didn't know anybody else that knew sign language. So we had to adapt.
Yep.
And so thankfully we had like laminated papers where he was able to like circle with a dry erase marker, like what part of his knees were hurting. And then we wrote fluent sentences on a whiteboard. And so every time he'd come in, big, huge, muscular, like sweet guy, it just big waves, and he was awesome. But it just, after he left and was discharged, we were like, we've got to learn sign language, because that was the first time we had really worked with somebody who was deaf. And we felt so bad because we couldn't, there was like a verbal disconnect, and we were just like, we don't want that anymore. So
Yeah. Well, interestingly, in the ADA law, and what it states is that the caregiver or the parent or even the client themselves do not count as an interpreter. It happens a lot, though. I even interviewed on my podcast a while back the adult daughter of two deaf parents. Now she's hearing and her sister was hearing, but both of her parents were completely deaf and her whole life. And both of them actually, her mother lives with her and has Alzheimer's. Her dad had a different neurodegenerative disease that didn't affect his cognition, but did affect his physical sense. And she's pretty big out there. I'll post a link to some of her stuff on Facebook and social media. And one of her videos in particular went viral because, and that's how I found out about her and invited her on the show, because she has a camera on the dashboard of her car. It's probably just a cell phone mounted. And she was having us, she's fluent in sign, obviously. So she was signing with her mom, and her mom, she took her mom by on a drive-by by their old house. And her mom kind of recognized it. And she said, I know this house. I've been to this house. Why do I know this house? And the daughter very skillfully, it's really artful, the way she kind of prompts the mom to realize things. She doesn't just flat out answer her. She kind of has her realize. And then in the course of the conversation, which is all happening through sign, and then she later like subtitles it, she said, the mom says, I remember I lived here with my husband, Manley, and I had two babies. Did you know them? And the daughter kind of works it around. And finally, you can see this realization come on the mom's face. And she says, you're my daughter. And it's so, I mean, it'll make you cry every time you watch it. It's so sweet. And the daughter's so happy that she realizes it. And I mean, they have all kind of really cute conversations like that. The daughter's really into CrossFit, and she gets the mom to do some kind of CrossFit exercises like in the kitchen and stuff, and the mom just goes along with it. The mom's always happy, and it's really sweet. But I interviewed the mom just about her role as a daughter, caring for, she's the primary caregiver for her mother with dementia, who is also deaf. And she brought that up and said at the majority of appointments they go to, which, they go to a lot of medical appointments, there is no interpreter. And if it weren't for her, she can figure out how the providers would figure anything out.
Yeah.
So it's, it's a big problem, really.
Mhm.
Good point. All right, well, let's
There's a
talk about,
girl,
go ahead.
I was just gonna. Can you hear me, Dr. Lancaster? I was
Yes.
just gonna tell a quick story. That there's
Yes.
a girl that with a group that I volunteered with for the last few years that was raised by a grandparent who is deaf and has a brother that's deaf, and so she learned sign language and was very fluent. And then in 2014 was in an accident and was hit by a car and then became blind. And so she's now blind and fluent in sign language. And so it's just this really awesome combination. But she, that's her dream job, is to be an interpreter for sign language. It's really cool.
Wow.
She also has, yeah.
That is very interesting, for sure. There's a lot of more technology out there, and sometimes in the school system we would use, if there was an interpreter, but occasionally the interpreter would be sick or just not there or something, we would use an app that it showed us how to sign, and then we could, some apps will even let you film somebody signing, and then it'll tell you what probably the word is. So that stuff's getting better, but there's no substitution for somebody that just knows it like that. All right, so let's talk about activity analysis. That's our second big topic of the day. What is it? It is the process of breaking down an activity into steps and other subparts and examining its components. So you're taking an activity that somebody's doing or you want them to do, and you're looking at all the different things that go into doing that. It is not just the steps of the activity. It's what cognitive skills, what motor skills, what social and language skills go into being able to do that. If somebody has no idea, let's say, how to make banana bread, they've never heard of it, they don't know anything about it, they don't know how to cook, they're really starting from square one. And I just hand them, 7 steps, the ingredients list and 7 steps, but I don't tell them what is a bread pan, what is nonstick spray, why do you preheat, or how do you preheat the oven, that kind of thing. What does a rotten banana look like as opposed to a green banana? Why does it matter? They don't have that other stuff. What I also need to consider is, how are their cognitive skills? How are their language skills? How are their motor skills? How are their visual skills? Can they open the cat? A lot of us have if you open like the utensil drawer in your kitchen, you have to be able to visually scan and then have decent visual perception to find the right tool that you need in there. It's not just a drawer with only one thing. So you're having to really analyze, thus activity analysis, not just the activity, but everything that goes into being able to do that activity. So it really is what we think of as the bread and butter of what we do in OT. It's one of the things that OTs are experts in. It's how we do what we do in a lot of our interventions. And if you look at in the O&H book, there's more details about this on page 155 through 159. That's in a chapter that's about intervention, and we're going to have a whole nother lecture on intervention to kind of go through more details of that. So really any activity can be broken down into performance components. Now I'm speaking OTPF lingo there. What I'm talking about is those performance skills, or in other words, all the skills that somebody needs to be able to do to perform an activity. That's a performance skills, but it's also the performance components. Remember, those are, the performance patterns. Remember, those are role, ritual, routine, and habit. So how does this activity fit into that? And that's kind of why we're the experts in a lot of ways on what motivates people and how what we're doing in the clinic or in the school or in the hospital or wherever you are, how that relates to somebody's real life, what really is important to them. So when an occupation or an activity is used for therapeutic purposes, which is so often in OT intervention, whether or not it works and you get out of it what you want from the client is really related to activity analysis and their motivation. That's why there's caret there. So activity analysis and the motivation, and that is part of activity analysis, is always part of what you do in OT. And the reason is because doing that ensures that we come out with, this is a big OT phrase, the just right challenge for each and every client. Now this, every time I start talking about what that means, it makes me think of the Goldilocks story, Goldilocks and the Three Bears. It's not, when the bed was too soft, too hard, and then just right, and the chair was too big, too little, and just right. It's, think about that in terms of an activity. If I give you an activity, if you come over to my house, I say, we're going to have craft day. All right. So you come over and I say, I give you a piece of paper with a circle on it. And I say, here's what you get to do today. Color in that circle. You're probably not going to love it. You are going to be bored because it's too easy. That's not the just right challenge for you. Now, if you have average arts and crafts skills, maybe somebody in here is an artist and this might be too easy for them, but for most people, if I gave you a piece of paper and a stick of charcoal and said, okay, I want you to draw Ruth Bader Ginsburg, go. Here's why I'm saying that, because this is something, forgot I was attached on my wall that I'll show y'all. Maybe you can see this. It is actually RBG. This is by a charcoal drawing by the one and only Dr. Weiser Pike. Can y'all see that? She and I got together today, not today, it was a couple months ago, for just kind of an arts and crafts session. And mine didn't look so good. And I was saying I didn't really like it. And she said, well, you can have mine if you want it. So I brought it home and framed it. And she didn't think it was that good, but I did. So, but most of us and most people out there would not be able to do that. So that's so hard that we're going to just be like, why did I even come? I can't do that. I don't even know how to get started. So that's too hard of a challenge. So what we're looking for is the just right challenge. And a lot of times how we get that is to analyze that activity and to look at how we might adapt it to make it a little harder if it's too easy, or to make it a little easier if it's too hard. That is the bread and butter of OT. That's a big, big part of what we do in OT. And it's why, that term adapt is used so often. So here's some things that we look at in doing an activity analysis. Now, in this class, you have an assignment to do an activity analysis, and I'm going to show you the report that you'll do. You just really fill in a form that you're going to do on an activity of your choice. But you're not going to do that all the time as an OT. You won't do it too many more times as an OT student, really. But what the purpose of that is is it trains your brain to think that way, because you really, as an OT practitioner, you will analyze activities on a daily basis. You'll do it almost in your sleep. You'll do it all the time. I mean, I even do it for myself. Sometimes, like if I'm this morning I was filling up a pan of water. I was going to boil the water. I was going to make some iced tea, and the pan was getting heavier and heavier as it was filling with water. And, my sink is divided in two. And I thought, well, that's dumb. I'm holding this and putting all this pressure on my wrist. I should just set the pan on that divider in my sink as it fills. So I don't, and then I can carry it over the stove. So I just adapted it because, I was thinking, why is it, I don't, how can I make it a little bit easier or less demanding of me? So always you want to think about the relevance to the client. You want to think about, this is kind of like the ingredients list. What all do you need? And that's not just, like if I said the charcoal drawing, it's not just charcoal in the paper. You also need a table and a chair, or are you going to do it standing? Actually, Dr. Weiserpike drew that standing in at an easel. She drew it. We were in the Nolan media room in the OT suite. And so somebody might want an easel to do that, but somebody might want to do it flat and sit at a table. So then you would need those. What space demands? Should it be indoor, outdoor? Do you just need a little space, or do you need a big wide open space? Like if you're going to teach somebody how to do a back handspring. What social demands? Now, especially if you're having to share materials, if you don't have something you need and you're going to have to go either maybe try to find it or ask somebody about it, that could be a social demand. The sequence and timing. So knowing, what comes first, what comes next, and pacing yourself. So if I know I have 1 hour to do this, I can't spend the whole time just reading the directions. This is a big one, relates to the OTPF, the performance actions and skills. So that's, what all do you need to be able to do physically, social, emotional wise, cognition wise, visual perceptual wise, all that stuff to be able to do that. And then required body functions and structures. If you have a headache, if your stomach hurts, if you didn't sleep well and it's, making your eyes feel weird, that's going to affect your ability to do whatever activity. And you need to consider all that when you're thinking about how to provide the just right challenge for every client. All right, so I mentioned that we always want to look at the steps of an activity. So I'm going to have you guys watch a video. It's really short, about an activity, and it is making brown bag microwave popcorn. This is where you can make microwave popcorn for just a few cents without buying the pre-made bags of it. And so, but rather than just thinking about that, what I want you to notice is, and think about when you're watching this, it's like 30 seconds, is what are the motor skills that are involved? What do you think that, like, the cognitive skills and any performance skills that might be needed? So maybe jot those down, or make sure you have some in your head that you get from watching this. What would somebody need to do this activity as it is? So right now, think we're not adapting the activity at all. Just as it is, what do you need to be able to do? Here we go. There it is. So that person either moves really fast or somebody fast motioned that. But I think you get the point. So I'm going to count to 3, and I want you to put any performance skill you noticed in the chat. What is one thing that you need to be able to do, or anybody who's doing that activity needs to be able to do? Yes, yes, yes. Good, good. Oh, push the button on the microwave. Yep, because that wasn't even shown in the video, so you really had to think about that. Pouring, grip. A lot of wrist movement. Yes. Somebody said follow directions, and I like that you said that, because I think, notice that most of y'all are talking about the physical, and that's fine. You definitely need that, but don't overlook that other stuff. Okay, what about safety awareness? That's always something that needs to be in there, and it mentions that at the very end of this video, that the person needs to be able to watch when it's just coming out of the microwave. It is hot. I mean, if you've ever burned yourself on microwave popcorn, that's not fun. So they do have to have even elbow movement to shake it the way, to open the bag. They also have to be able to grade the amount of pressure they're putting on it. Otherwise, they'll crumple up the paper bag there. So it's a lot of things to think about, that even that timing and sequence, even though the direction says 2 minutes to do it in the microwave, what if it didn't really pop in that time, or only 5 kernels pop? So you have to have kind of problem solving sometimes. It really depends on how powerful or how big your microwave is. And then also to know, if you hear it finish popping, or it's pop, 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 and then it stops, but the microwave still has another minute, you better get it out of there. You're going to stink up the whole place with a burned microwave popcorn smell. So you do have to have those troubleshooting, problem solving, and safety awareness skills too. Okay, good. Y'all are already thinking in terms of activity analysis. So why do we learn to do that? Why did I say that's the bread and butter in OT? It's because we look at, first of all, the roles of people and their occupations, and what's important and valuable to them. What is their daily routine, habits, all that looks like. I mean, maybe somebody tells you, I hate popcorn. I would never cook microwave popcorn. I can't even stand the smell of it. So it'd be good to know that before you think this is going to be, something big you're going to do in a treatment session. In short, it gives us the insight into what somebody needs to work on, and then we match that up with what an kind of skills or practice an activity provides. So it's like going to match.com for what the client needs to work on and what an activity will allow them to work on. All right, if you are curious about and want to look at more about this, go to the blog Cooking Mamas, which is cookingmamasuk.wordpress.com. And that will give you a look at some more activity analyses. To me, an easy way to think about it and how you would do that is to think about cooking kind of things. You also could think about games, that sort of thing. I mean, you could do it with any activity, but just for starting, sometimes those things are the easier ways to do it. All right, so when you look at adapting or making the challenge either harder for a client or easier, you're always thinking about adapting, always with a goal of providing the just right client challenge for the client. Maybe you plan to do that microwave popcorn thing, or to have the client do that as an activity one day in a therapy session, and they come in and they say, no, what do you do first again? Do you put the salt in first, or do you realize pretty quickly that it's too hard. They, for whatever reason, it's really above their level for that day, and it's kind of putting them in the too challenging category. So what are some ways, and I'm interested to hear, and you could put it in the chat or say it out loud, what can you do? What would you do if that happened to you?
This made me think of when I was doing some observation at Madonna.
Yeah.
And we, like, once a week would go down to the adult program and work on something with them. And one of the weeks we were doing puzzles. And so we brought down the puzzle. And, you know, my sister Lindsay and other people that I've interacted with who have special needs, a lot of them are insanely good at puzzles and completely understand how to do. So I was like, oh, this should be good. This will be really good. It's like something that they probably really enjoy.
Yeah.
It was a very big struggle. Like the entire hour, we got the borders all taken out, the big thing of it. And then the next week we focused on like doing the colors and different things, and then like working all that together. And it was just like interesting. And the OT I was working with too, she was like, yeah, she's like, that's okay. We're just gonna do it this way to where it's working on it together. And yeah, so it made me think of that, because we went in there thinking it was going to be one way, and then quickly found out it was not going to be that way. So kind of just like, let's just
adapt. Yes.
Yeah.
Yes. Thank you, Jenny. That's a perfect example. Really, I'll maybe use that in future class sessions. That happens all the time in OT. And I actually kind of like it when that happens. I don't feel like somebody ruined my plan, or I had this perfect plan and now it didn't get to happen. But I more so think it having to adapt on the spot like that to make the Just Right challenge happen for a client keeps the job at the Just Right challenge for me. I mean, if I knew that every intervention I planned was going to go smooth as silk, in all honesty, I'd probably be pretty bored. Or somewhat, it wouldn't challenge me. Caitlin says she took care of somebody that was recovering from a stroke who likes to cook from scratch. Yes. And it's interesting. You mentioned she was from a different culture than you. So that's a situation where you're learning from the client as the client's learning from you, which I think that's a perfect therapeutic relationship. Yes, exactly. I love that you said that. All right, so let's move forward. All right, this is it's a robin that we found as a baby, had fallen out of the nest, or the mom pushed her out of the nest. And we raised her until she was ready to go into our backyard. Very funnily, I think my young daughter, who was in first grade at the time, named her Tipsy, which, people use that for a term meaning somebody's drunk. So everyone thought her name was funny, because my daughter named her that just because she had terrible balance when we first got her, because she was a baby. So this is Tipsy. And once we released her in our backyard, she would come back to us regularly, especially if we had blueberries. She loved blueberries, and you could hold one out in your fingers or put it in your hand, and she would come flying from wherever she was. And she would make this certain kind of bird noise. And I still can recognize robin noises even years and years and years later, because she would make that noise, meaning I'm coming to get that blueberry. Whoops. Okay. No, Adobe, I don't want you to update right now. So here she is. And the reason I have her here is I want y'all to do a little activity that I call the round robin activity. So I'm going to put you in breakout sessions, but before I do that, you're going to need the worksheet that is on Blackboard under today's course content. So make sure you have that. And what you're going to do is work with a partner, whoever you're randomly assigned to think about, I have a list of 15 activities there, and I want you to think and write on the sheet how you could make each of those things a little easier or a little harder. Just for you. Don't imagine there's somebody with a disability or whatever, just for you. If you went in or anybody, and what activity I said, like the popcorn thing, if it was too easy, or the puzzle example, or the Indian cooking example, if it was too easy, how could you make it a better challenge? Or if it was too hard, how would you do that? So I'm going to give y'all about 10 minutes and then I'll call you back. So, and you should fill in that worksheet, but you're not going to have to turn it in. Welcome back, everybody. We're waiting on a few more to come on back. Should be back in just a few seconds.
Dr. Lancaster,
Yes.
I know we talked about it, but I can't remember what you said. For the Jeopardy night, does that count toward our professional development hours?
Yes. Yes. Yeah, I think that's a good question because it seemed like a game night or whatever, but it was, you know, it is a learning activity. So the faculty felt like that was completely valid for y'all to count for that time. Thank you. And you don't ever worry about asking me that stuff at all.
No, I'm not that Debbie. That's cute.
I didn't
Super
realize I was
cute.
muted. I was like the whole time, and I was like, oh, I was unmuted.
All right, so we got one more thing to discuss and then I'll set y'all free. This is the activity analysis report. So you're going to do what we kind of practiced in looking at, and basically you're just going to go straight down this and fill it in. You see the points that everything is worth. So that's essentially, I'll just go down and check those boxes, if you've covered what's in there. You are analyzing an activity and you're going to fill all of it in. Now, question people always ask me is what should go here for reference list? And that is if you get the activity off Pinterest or YouTube or out of a book, craft book, or something like that, you can list that. But you might, if you just get it out of your head, or it's some game like this sounds really country, but my siblings and I used to sometimes play games with rocks in our backyard that we just made up when we were young. And So sometimes it just comes from nowhere, and you can put, from my head, or, no outside resources were used there. But if you do, yeah, we didn't have video games, so your mom and I had to play with rocks and sticks before we walked uphill both directions to school, when we were kids. So this is this report is available for you to download, and all the details, including due date and all that, are all under assignment, the assignment tab, and then look for activity analysis, and it's everything you need is right there. Now, one thing I do want to call your attention to is, we're going to do those review questions next class, but if you look on Blackboard, you will see that there is a link that you go to, and really kind of step one of this assignment is to choose your activity. You can choose whatever you want, but it needs to be something that takes at least 5 minutes to get through, and something that doesn't take more than 30 minutes. So, don't let it be like making a 4-course meal or something, because that's going to be too hard on you, really. But one year somebody did doing a somersault, and that really doesn't take that long. So choose something that takes a little longer. If you're thinking about what you might choose, if you think about any sort of IADL activity, a lot of ADL activities, games, things like that, definitely cooking recipes. But if you think in terms of IADLs, it might help you get an idea. So first is, anytime you're ready, sign up to choose your activity. It takes you to a Google Doc. We got a couple people doing the examples already. I often use, if you guys hadn't noticed this already, my imaginary OT friend, her name is Olga Thompson, get it? Because her initials are OT. And I often use her as examples for things in the classes I teach. So you'll see that a lot. Like, she has a really terrible resume that will just rip to shreds in a future class. And, sometimes she does assignments really wrong. So that'll be the example of what not to do. All right, we have a lot of anonymous coyotes, rabbits, squirrels, kiwis in here. So I would much prefer if you don't do something that somebody else already has. So try to avoid that. You don't have to put anything in the comments box unless you just want to tell me something. If I see that it's something that I don't think it's going to be the best for you, if it's going to be too hard for you to do it or something, I'll just email you and tell you. But basically, it's your choice, and you're going to go through that whole thing and do that assignment. So you'll see what is under there. This is all straight from the syllabus. It's due March 29th. Now notice how much it's worth, which is, it's a lot in terms of, considering your exams are just worth $150 here. So you can really help yourself if you didn't love your exam score. Now, one other component is you're going to do this written report using the template. The other thing is you're going to take, or have someone take of you, a video demonstrating that activity. And then you can put the video on YouTube or, Dropbox or wherever you want, but you're going to also submit the link to the video. So that I know you've kind of gone through the activity and thought about all the different steps and performance skills that are needed. So if you look on that report, you would see, you'll see there's a place for you to put the link to it. All right, any questions about that? This is one, people always like this, and it's kind of like the Arrow Project. Most people always like it. And, when we can meet in person, we've had activity analysis lab where instead of doing videos, people demonstrate their stuff and even will kind of guide a small group of people through it. But of course, you know, we can't really justify that to be on campus. This is the time when this is due is right at the time we had to go off campus last year. So the students had to really quick make videos instead of doing it in person, but they adapted. So